Good evening to you all. Thank you so much for the nice introduction. It's nice to be here. Thank you for the invitation. I'm very glad to be part of this first international online symposium of Knightsbridge Academy. I didn't know I was going to be introduced nicely as such, so I already prepared some introduction for myself too. So quickly, as I won't be able to change the presentation now, I'll quickly also go through introducing myself. Okay, oops, sorry. Okay, as I was introduced, I graduated from the Hacettepe University. I'll quickly pass this part for you. And then I took a position in Konya Selçuk University as a research assistant. After that, I went to London to study at the Eastman Dental School, University College of London. And afterwards, joined the Cyprus Health and Social Sciences University, and currently I am also lecturing in full capacity. When I say in full capacity, of course it's not full time, but I allocate some time of my clinical and also theoretical part, lecturing students in Cyprus. It's quite nice. I've been to actually Dubai a couple of times. I don't know how many times I've been to Dubai over the past years. It's a very nice place. I hope one day I can revisit Dubai. I have really nice, good memories being there. Cyprus Health and Social Sciences University, we have actually very recently did a graduation ceremony. It was yesterday, or the day before yesterday, sorry, and I was there. And it was a great honor for me to be part of the graduation ceremony in Cyprus. We have international students, also local students. And as you all know, due to the pandemic, we have now online courses, online lectures. Hopefully it will change next year, and then we will, as students also mentioned that they really missed sharing time with us, with the lecturers, and hopefully it will change over the coming days. I am a founder of Dental Clinic in Istanbul. This is a multidisciplinary clinic. We have 7 doctors working in our office, and I am actually very happy to be part of this multidisciplinary clinic. It really makes life easy, and then also contribute and boost the quality of treatment, because I was also before in Ankara a part of a multidisciplinary clinic. So this is the way I like to work actually. So by having such an office, then I can allocate more of my time on my special interests. And as you can see here, we have pedodontics and surgery, etc. Now, let me just close the tab so I can see the slides better. I'm talking and sharing my, there are some people still admitting. I'm talking and lecturing, I don't know how many years, very long time. And while we are doing that, we also did some studies, as you can see here, in Journal of Aesthetic and Restorative Dentistry. It was, I think, in 2019 or 18, sorry. And you can see the success rate of the veneers 98% after 5 years, and then 91%, sorry, 98% 5 years, 95% at 10 years, and 91% at 15 years. And over 20 years, it was 87%. So this is a really great success rate. And we can actually, with a peace of mind, continue doing these restorations. Currently, of course, the techniques have changed a little bit. And I'm sure if we start a new study, after 5, 10, 15 years, the success rates will be even higher. That means the restorations are very successful in years, and we can really have a peace of mind to apply without any hesitation whenever it is possible. And throughout the presentation, I'll give you some hints and tips why we should be actually doing the veneers. It is more. It is coming in the following slides. Actually, you will see. This is Journal of Aesthetic and Restorative Dentistry. 2019, we also published the retrospective lens after 10 years. 10 years results again. So very promising, in line with the study results. At this study, professionals for the application, it short video how we do these courses. And it's not only veneers, of course. I lecture on digital registration of jaw. So why objects, but mine ceramic veneer. And during these courses, we actually share these at the end. Hopefully no one point missing, and we get lots of questions. We answer all these questions. So it's exchanging knowledge and experience altogether. One by one, take care of all the procedures, and then showing how to do the preparation, taking impression steps. So the feedback is always very good, and the participants always leave happy and start veneers applications next day in their office, usually Monday, as we do the courses at the weekend. By Monday, they start their new cases. So this presentation actually just a teaser, of course. The veneers, very wide subject. We can talk for hours. These are a few cases. This slide I always use, without any exception. All these courses, I use this slide during also the student training courses. Just a nice looking restoration doesn't mean a successful restoration. This is very important. Successful restoration should comply all these factors, should comply with the biology of the surrounding tissues. The mechanics should comply about. And then the function is, of course, the most important. In it is the most important for the patient, but in reality, the function is extremely important for the successful restoration. And a few days ago, I had a patient, a German lady, came to my office. When you look at it, everything looks fine, but the patient is complaining. And this, I always tell the participants of my courses, you know, having a nice looking teeth is not the end result. A successful restoration should have much more than a nice looking restoration. Okay, when you look at it, there is no major problem. The biology is fine. Okay, there are little issues maybe, but no major problem. And this case is actually shared on an Instagram page. It is done in Istanbul, in a very famous, one of the famous, let's say, dental clinics. But patient is not happy. Patient is, she wants to have them even replaced. Why she's not happy? Okay, again, looking at the picture, not bad at all. The shape, and as you can see, the surface texture, etc. It is obvious that a good technician worked on this case. You see, the patient actually described it as it feels like a razor. See these points. Why do we have to do that? Okay, we are not actually fabricating these veneers for ourselves, for our photos, for the comfort of the patient. That should be taken into consideration seriously. Okay. Now, look at the premolars. Do you think there might be something odd? I just want to point your attention to this difference, level difference. And patient also complain about the color, because this is probably not enough thickness of the veneer, or not enough preparation. So the color is reflecting beneath the ceramic veneer. Okay, but at the surface value, looking at it, there is not problem. Just looking at it, it would make a nice Instagram photo. Huh? It's due to people admitting I have to accept them. Harmony. Have we seen this case? Yes. If you can just confirm. Yes?
Yeah.
Okay. So, as I said, biology, mechanics, function, aesthetics is very important. In this case, as I said, there are some problems, but on the face value, there isn't a serious problem. It would make a nice, as I said, Instagram photo, but the patient is not happy, so there is a problem. You see those edges, is like a saw. This is what the patient said. And the premolars, the level difference with the molar and the second premolar, as you can see, there is a problem with the occlusion, harmonious occlusion. And the color, as you can see, this is due to either lack of preparation or the thickness of the veneer was not properly done. So one of the major problems in restorative treatment is the lost occlusal harmony, as we all know. And many times this harmonious relationship is altered by restorative treatment, or earlier, as I said, through orthodontic treatment. I had one patient today, and she was 21 years old and already had TMJ problems because as a result of orthodontic treatment. The closure was fine, but occlusion is not static, it's a dynamic issue, and just a closure is not enough for a successful functional teeth relation, jaw relation. Okay. In the occlusal relation, contact should be in harmony with muscles and the temporomandibular joint, it's obvious. So what are the minimally invasive approach? And then biologic harmony, of course. Then meeting patients' high aesthetic expectations are the major advantages of all ceramic restorations. And believe me, the real showcase of dental clinics are the patients leaving your office with the smile of their dreams. So every patient leaving your office with a nice smile, with a happy restoration, with a smile of their dreams, they act as a walking billboard for you. This is amazing. And every patient leaving your office with a smile like that will bring many more patients. Therefore, veneers, smile design, whatever call it, is really imperative in your success, clinical success. And do your patients know exactly what they want? I asked this question all over the years, and 10 years ago, even 5 years ago, the answer when I asked this question would be, no, they just want a nice smile. But today, thanks to social media, patients know exactly what they want. They even ask you the material, what material will you be using? What is the cementation material, even that, you know? So really, we need to know more about the material. We need to know more about the ins and outs of veneers. As I said, real showcase of dental clinics are the patients leaving your office with the smile of their dreams. No, all my patients, when they come to my office, they have a history. They have some story to tell. And this patient came with an urgency of having her front teeth, let's say, restored and to have a nice smile, basically. And what we did was only 6 veneers from canine to canine. The patient was about to go to Ukraine, and he wanted to have a nice smile. I don't know why. But we did what he wanted, and he was really happy. And we did that in, I don't know, maybe a couple of days, and the patient is very happy, leaving your office and advertising you all over the places, even in Ukraine. And this is a patient, she is from UK, but another point, not everyone like it natural. we have to respect that. You know, we don't have to force anybody to have, of course, we can advise, but we cannot really, we should not force anybody to have a different color, different shade, and we should mutually agree and then talk about what material to choose, what color to choose, etc., and come to an agreement at the end that would make the patient happy. The patient's happiness, the patient's acceptance is much more important than mine, because I'll be seeing them maybe a couple of hours, a few days, but she'll be seeing herself over the years. Every time when she look at the mirror, she will see and then either appreciate or disappreciate what we have done. When I had this patient, I really had a shock because I never seen anything like this before. It's a sclera tattoo. And when I first saw this patient, his eyes were closed, and when he opened his eyes, I was really shocked. And this patient also has a story. It's a long story. We will talk about these stories more in actual courses. But as a short story I need to tell, this patient had this look, and the restorations in his mouth, they are not just metal, they are dental gold alloy. Patient had quite a lot of good background, hard to believe, but a good background, very good articulation. When I say articulation, the manners, good speech, good speaking, and basically, when I asked why you want to have your teeth to be changed, because there was no problem at all, he said he had a normal girlfriend. That's why he wanted to have a change of his look, change of his life, etc. And I said, it's going to be difficult to change all these things and tattoos in your face. And to be honest, the look on the left probably suits him better than the look on the right, but it was his wish. It was what he wanted. So we gave him what he wanted, and he's gonna in time peel off all these tattoos. I know this is a very difficult procedure, but he is slowly taking steps. So which material? This is one of the most important parts. And okay, should I use translucent or opaque material, and when and where should I use it? So this is a dilemma, and this is one of the most important part of the veneer fabrication. Selecting the most suitable material for your clinical case, both shade of the prepared teeth and shade of the final restoration should be taken into consideration. And therefore, effective communication with dental laboratory is the key to successful restorations. So I always say, whatever you do, please have an effective communication, good communication with your dental laboratory, with your dental technician, because we are a team, and without a good dental technician, we cannot achieve a successful restoration. Believe me, please. Okay. And what are the criteria for selecting the most suitable ingots or cap blocks? As we mentioned earlier, the targeted tooth color. So what is the final restorations color? What we achieve for the final restoration? What's our target? And then prepared tooth color is important. And the restoration type, whether we will be fabricating inlay, onlay, veneer, full crown, and the thickness and the depth of the restoration, technique to be applied. Are we going to do a cutback technique? Are we going to use a cutback technique or layering technique? And the cementation material is also important. And we use these shade tabs to decide on the shade of the final restoration. And we also need to transfer the information about the prepared tooth to our dental technician. And as you can see here, let's say the final shade of the restoration A2, this is what we achieve, what we want to achieve. And then prepared shades, prepared tooth shade is ND, which is a natural dye. This is a different shade scale, let's say, and then we need to transfer this. Either we can do it with the shade tab, or we can do the transfer with our photographs. This is also an option. So when it comes to the lab, dental technician can use all of these materials with different techniques. Like if he needs to use medium opacity ingot or block, then he needs to use layering technique, because medium opacity will look too dull, too opaque. So we need to add some layering ceramic to make it alive, to make it more aesthetically looking, more transparent looking restoration. And we can do LT, A2 cutback technique, or HT staining technique could be used. These are all options depending on the restoration, depending on the preparation depth, etc. And what type of material should I use? What is the importance of light translucency? Always the question, always the most difficult part of these courses to understand. It's actually not that difficult. We'll go through briefly. If we have a dark teeth underneath, dark shade, then our options are different. Again, we can use MO, HO, high opacity, medium opacity, or cutback technique, but it is not possible to use high translucency ingot. If we do, we will have failure. Why? Because the underlying tooth color will show, and then, as we have seen earlier in slides, and then we will have a failure. We will not achieve the color we targeted. Okay, we always share a photograph like this with our dental technicians, and we do little drawings, tell them exactly what we want and what to do, what is right, what is wrong, all these explained in detail. So this actually makes us save time, because by doing that, we achieve the results we wanted, and then dental technician understand exactly what we meant. Because otherwise, just telling the dental technicians, just a little bit here, just a little bit there, doesn't mean anything. What is just a little bit? Just a little bit here, just a little bit there. So this is positive, objective data transmitting, and then dental technician can say, oh yes, I can see the problem. Not just a little bit lighter, that's just a little bit darker, doesn't mean anything. This is an implant over superstructure case, but here also we also share with the dental technician what the problems. The front midline needs to be shifted, etc. All these details are shared. So to be able to produce veneers or ceramic restorations, we have two methods. One, pressing. The other one is CAD/CAM technology, as you all know. Actually, there is one hybrid technique too, which I quite like. In that case, you can combine these two methods in one. How do we do that? Your dental technician can do the CAD-CAM procedure on wax, carving on wax with CAD-CAM, and then can do the pressing. So you will have the best of both worlds. All these subjects, of course, very detailed. We can talk, as I said, during the actual courses. I won't bore you too much. This is important. I won't give you too much academic information. But here in this slide, you can see a veneer restoration. We remove only 3 to 30% of the intact tooth substance, while 62 to 72% if we turn that into full crown restoration. This is very important. And this is 4 times more than veneer restoration. So let's put ourselves into our patient's place. What would you like to have? If you can have, of course, I mean, if the indication is correct. Would you rather have a veneer, which is minimally invasive, or a full crown preparation? And the failure rates for full crowns after 10 years, as you can see, 15 for single unit crowns, 30% if fixed bridge abutment teeth, if it's used as for a fixed bridge, then the after 10 years failure rate is 30%. After 15 years, it's 19 to 34%. Again, a little bit of empathy. And initially, from the beginning, you have seen the success rate of veneers. So wherever possible, please choose for veneers rather than full crown restorations. And what are the criteria for selecting the most suitable ingots or CAD blocks? This is the question, and this is a difficult topic. And I know you all think like that, seeing all these variety of materials. But in general terms, we have different light transmission properties in these ingots and in these blocks. So for the successful results, we really need to know the dental materials, and we should be in control of our restorations rather than leaving everything to our dental technicians. So we can of course discuss and get an idea, etc. I'm not against that, but we should first know the material's properties. Like high opacity, when we say high opacity, we mask the underlying tooth. And then medium opacity, as you can see, the line can barely be seen. And low translucency, as you can see again here, we can see much more than medium opacity. And high translucency, we see more clearer. And all these, among all these, later on, the company of material producing companies added one more ingot, one more block type. This is a medium translucency ingot, and believe me, this is one of the most widely used in our clinic, at least. So many admittance. I'm sorry. So we can use these medium opacity 14 veneers, cupless veneers, occlusal veneers, crowns and partial crowns, 3-unit bridges up to second premolars. So wide variety of indications covered with these materials. And we should always remember that the system is strong as its weakest link. So if we have a good material, but the layering material is weak, that means the chain is broken. So we have to be careful while we're choosing the right material. Full contour zirconia materials are very popular. We will also talk about these throughout the courses, very popular, and they have really good properties. In recent years, the values of strength and translucency is gradiently combined in these materials. So we have the aesthetic look of almost, not as much as glass ceramics, but at least good aesthetics with the addition of 5 mol yttrium stabilized zirconium polycrystalline to these blocks. So we have the good aesthetics, but also without compromising the strength, durability of the restorations by using these zirconium restorations. I won't go too much in detail, but this is, as you can see, more yttrium addition makes it more translucent, and the less yttrium infusion makes it, gives the material its strength. So we combine the best of both worlds. Then the same thing, dentin zone is the strength, then incisal zone is the aesthetic part. So medium opacity ingots, where do we use them? If we have root canal treated restorations and the color of the tooth is darker and then the preparation is quite excessive, that means if we don't use medium opacity, we will have the darkness of the mouth shining through, and then that means failure for the end result. So we could use medium opacity in such cases. Here, if we have a diastema case, we can use low translucent ingots. These are just examples. Again, as I said, this will be discussed much more in detail. High translucent, usually used in prepless or thin veneers, used for. Okay, low translucent, just you have seen before, could be a diastema closure case, more or thicker veneers. And then we have high opacity and medium opacity when we want to mask the underlying tooth structures. As you can see here, high translucency, much more light translucent. And then we have medium translucency, slightly more, or translucency is less than high translucent ingots. These are all on the same light source. And when we do veneer try-in, as you can see, the cementation material has an impact too. If we use high value cementation material, then we have a much more increased value, the whiter look as the patients most cases want. Or if we can make it, we can also make it darker slightly. These are all the same restorations, by the way, same material used. Just the using cementation material we can influence the final result of the restoration. These are the cementation materials. We can have dual cure or light cure. For veneers, we use most of the times light curing cementation materials. Curing lights are extremely important. Why? Because if we don't have a good curing light, even if we use the best material, as long as we don't cure it properly, it has no value at all. So please invest in accessories such as curing lights. A good curing light is a must in a dental clinic for successful results. Cementation is one of the most difficult part of the veneers. I'll just give you a brief introduction, not cementing veneers, but cementing and the crown, for instance. It's exactly the same procedure, and definitely we will discuss much more on this subject once we have the courses, real courses, and 20-second ceramic etching gel. This is a hydrofluoric acid, 5%. And then we rinse with water spray for 15 seconds, and then we blow dry. Then we use silane for 60 seconds, and then just similar to composite filling procedure, we apply 35% orthophosphoric acid and rinse with water and dry it. And then we apply, I use for almost last 5-6 years, I started using universal bonding agents. Before I had 3-step bonding protocol, but universal adhesives just as good, and the results so far after 6-7 years maybe, no failure at all. The good thing about universal bondings, the thickness of the bonding agent is 10 micron. So we can, with a peace of mind, cure the bonding agents. Before, in the 3-bottle system, we were not curing until the end, the stage. So now we can, with a peace of mind, as I said, cure the bonding agent and then continue with the cementation of the veneers and the crowns and the crowns. And one hint, tip, a small information to take home. If anybody tells you that the veneers are failing and debonding, whatever, as long as you're in enamel, 1 millimeter square enamel actually measure approximately 4 kilogram bonding strength between glass ceramic and the cementation material. Therefore, there is no way, as long as there is no technical problem, no way a veneer can be bond from the mouth. But if there is a technical problem, of course, it is possible. But over the years, I never actually come across, in our clinic, the ones I cemented, never experienced such failure. So we applied the cementation material. One of the most critical part is putting a pressure while curing, because if you don't, the hygroscopic pressure will push the restoration up, or in veneer case, will remove the veneer from the surface. Therefore, this is a small, but actually for a success, a large tip. Then we use the floss to remove, before the final curing, remove the excess from the interproximal areas. And then, as you see, achieving a result. And this is more extreme case. I'll go fast here. These are the things actually asked throughout the years, how to mask this discolored tooth. For instance, here we used an opaque mask, but you can also use bleaching, internal bleaching, whatever, it's up to you. Still people coming in. As I noticed, taking pictures, this is one of the tips I just want to share it with you. There will be a lot of tips like this. Mesiodistal dimension of upper central incisor equals nearly mesiodistal size of first lower incisor and half the size of second incisor. So this is just a small tip. Once you get stuck, you can actually have these measures and then use it in your clinical applications. We etch the surface with hydrofluoric acid, then orthophosphoric acid 35%, rinsed, blow dried. universal bonding application, then curing, restoration, silane application, and then here we use the dual curing cementation material. And the end result, right after the cementation, is quite pleasing, in harmony with the surrounding tissues, and aesthetically is pleasing. Patient is happy, more than happy. I think our time is over. There are much more cases like this. This is an extreme diastema closure case. I'd like to share not just regular cases, but extreme cases like this. So we just want to see, I just want you to see our limitations, what we can achieve with all ceramic restorations. Otherwise, I don't want to advertise myself. Look how good I am, how wonderful works, how wonderful smiles I make. And then I just want to share with you the ins and outs of all ceramic restorations, and what to look for, what to care for. And as you have seen earlier in one of the cases, which could be nice looking restoration, but if it's not functional, if it's not in harmony with the biology of the surrounding tissues, then it is not a successful restoration. Yes, I think, I mean, I don't know if we have time, but I don't want to disrupt the flow program.
Yeah, we have few minutes, Professor.
Okay, let's see this case at least. This is an extreme diastema closure. As I said, all these patients, they have stories. This patient is an estate agent, and patient, when he came to my office, he said, well, I am taking lots of people to show the properties, but instead of looking at the properties, they look at my teeth. I'm not happy about that, and I cannot sell properties. They concentrate on my teeth. This is a joke, of course. But he was very unhappy about this look, and it's understandable, really. This was an extreme diastema closure case. He's a smoker, as you can see. A close-up photograph. So what we have done is actually a little bit of illusion also. It includes an illusion. We just shifted from taking from the distal side, adding to the mesial side, taking from the distal side, adding to the mesial side, and then adding on the mesial side of these laterals. We just closed the diastema. So this is the end result. As I said, we used some illusions. This is how it looked from the inside. It was like this. And it became like this. The more striking change you will see now, the patient was looking like this. Now, everyone will look at his properties, not his teeth. Or maybe some people will look at his teeth too, or his face, let's say. Okay. So it's not difficult to achieve these results if you know the material, if you plan correctly what to achieve. The planning is the most important part. As the time is very limited, I cannot stress out all these topics, but a good planning is more than halfway to a successful restoration, successful result. He has become a handsome man. Okay, this is maybe last case. This is also a very interesting case. Okay. The patient, 17 years old, had orthodontic treatment. As you can see, the spots, she's not happy with the way she looks, understandably. And initially, for this patient, when she came to my office, actually she had implants planned, but patient was scared and she didn't want to go through the implant procedure. And her mother came to me and said, "Doctor, is there anything can be done without the implants?" I said, as I have also daughters, I said, I'll do something and let's see what we can achieve. So we started with a planning first. This is the initial picture. Not happy at all, understandably. This is intraoral. We did first wax up and then mock-up. Transferred the mock-up in the patient's mouth. During the mock-up, we also checked the occlusion, as you have seen. So with the mock-up, already I can see, yes, we can achieve a good look. We can do something about it. And this is the intraoral pictures of the final restoration. Here, just notice that a cantilever supported by a veneer on canine. You won't see it anywhere else. And almost 8 years old, this case, and no problem at all. She's still very happy. So it is possible in the challenging anterior region without implants, a good appearance like that too. You see? Canine, veneer, and then cantilever, lateral, but the occlusion needs to be taken into consideration seriously. Okay, this is the anterior guidance checked. So we have no contacts on laterals, with anterior guidance. This is the final restoration. So this is the final look of the patient, and you see even the spots on the way. This is where we started. This is on the right where we ended. So, okay.
Okay, thank you very much for a great presentation, Professor.
Much more cases, but as I said, hopefully we will have a chance to discuss all these cases more. As you know, veneers, very extensive, wide subject. So 40 minutes, unfortunately, this is all I can share with you. Thank you for your attention. And if there are any questions, I'll be happy.